Good afternoon, everybody. Thank you for joining this latest episode of HBMA Live. We're going to wait just a moment, give people a chance to connect. Today, we have two special guests to talk with us about what's been happening in Washington, D.C. with policy, with legislation, regulation. We have our esteemed Director of Government Relations, Bill Finerfrock, and our Associate Director of Government Relations, Matt Ryder. Good afternoon, Bill and Matt. Thank you both for joining us.
Thanks, Kurt, and thanks for allowing us the opportunity to talk with some folks today.
And Bill, just chatting earlier as we were preparing for this session, I understand there's some breaking news or some pretty hot news you want to share with the HBMA community.
Yeah, I think it is. And there's still a couple more steps to go, but we're seeing some substantial progress by the Congress to prevent some payment reductions that are looming on the near horizon here.
Mm-hmm.
As everyone is probably aware, if you've been following what we've been putting out, they 2% sequester that providers had been subjected to had been waived as a result of the public health emergency. And so you were getting the full 80% of the Medicare allowable during this pandemic. However, legislation had been passed to take that away and to reinstitute the 2% sequester. Congress, the House, the other evening passed legislation to continue the waiver of that, albeit temporarily, but and we're expecting the Senate will follow suit here in the next day or so to prevent the 2% sequester from reemerging in the near term. So that was good news, number one. There's also there was also the potential that there was going to be a 4% cut in Medicare payments as a result of something called statutory pay-go. Statutory pay-go is a federal law that essentially says that if the Congress passes legislation that is not paid for and substantially adds to the deficit, then the Office of Management and Budget is authorized to make across-the-board cuts in certain mandatory spending programs, including Medicare, in order to offset the cost of that deficit spending.
Mm-hmm.
And when the Congress approved the American Rescue Plan earlier this year, it did, in fact, add to the deficit. And so based on that, the Office of Management and Budget at the end of the year is authorized to make cuts in mandatory programs in order to close that gap. And the estimate is that the Office of Management and Budget would have to institute a 4% cut in the Medicare program for both physicians and hospitals, everybody in the Medicare program, in order to do that offset. Now, this type of situation has occurred in the past, and Congress has historically waived this statutory pay-go, so these kinds of cuts have never happened before. For whatever reason, they didn't do that as part of the American Rescue Plan. And so that means Congress now has to separately pass legislation to waive statutory pay-go. Otherwise, these cuts are going to kick in. In this same bill that the House passed the other night, they postponed and they said no cuts based on statutory pay-go in 2022. However, those could come in 2023. So again, it's not a permanent elimination of that. But right now, again, assuming this is passed by the Senate as we expect and it goes to the president, those cuts will not occur on January 1. And then finally, as many of you will recall, in 2019, CMS announced that they were going to do a revaluation of the evaluation and management codes under the Medicare program, that those code values had gotten out of whack. The pricing on it, the cost of it, et cetera, were undervalued relative to the cost. And so they undertook that and instituted changes in the evaluation and management codes in order to bring them up to more current values. In order to do that, however, Medicare on its own doesn't have the ability to just unilaterally increase how much is going to be spent by the Medicare program. It has to operate under something called revenue neutrality. So if the agency says, we want to increase spending by $50 million in this program, then the agency has to find savings elsewhere in the Medicare program of a comparable amount in order to offset that and come out with, so that the policy change is what we call revenue neutral. So when they put through these evaluation and management changes, it was going to substantially increase Medicare spending for E&M services. And so internally, they had to make adjustments to account for that. That meant that codes, non-E&M codes, in many cases, were going to be substantially reduced, resulting in cuts to a significant number of providers, and in particular, some of the specialties.
Mm-hmm.
Radiology, for example, was going to get hit. Some of the surgical specialties were going to get hit, anesthesiology, et cetera. And so those specialty providers were not too happy about it. In order to try and mitigate the effect of that, Congress authorized last year in December a one-time increase of 3.75% in what's called the Medicare conversion factor. And so the effect of that was, we'll even though the code values may go down for some areas, we're going to increase the conversion factor of what Medicare pays. And so at the end, we'll make you whole, or as close to whole as we can.
Mm-hmm.
But that was a one-time bump up. Here we are a year later, those same code values are at the lower level, but now there's no 3.75% to offset that. So the provider community, HBMA, as partners with the providers, have been urging Congress to do something to, again, help mitigate the effect of those reductions in the code values.
Mm-hmm.
What the Congress approved the other night, the House approved, was a 3% bump up in the conversion factor in order to mitigate. So slightly less than the 3.75, but you'll get a bump up in order to help mitigate that. And,
right.
And what I think that indicates is they're going to try and create a glide path to where eventually the full impact of those E&M codes will be felt, but it's not going to all occur in 1 year as it would have. We're going to spread that out. And so my expectation is that next year at this time, we'll be looking, Congress would do, let's say, a 2% bump up.
Right.
Maybe the following year, 1%. And then in the third year out, then the full impact would be felt.
Yeah.
So those were all done as part of legislation approved by the House the other night. And it's attached to legislation to increase the debt limit, which is something we also have to get done here fairly shortly.
So that makes it pretty much a certainty that this will pass. Then I mean, something can always go wrong, but it's very likely it'll pass.
We feel a lot more confident in this and the prospects that Congress is going to deal with it than we did about a week or so ago.
That's great news. Great news for you to share with the community.
So yep.
And then, what you described also sounds like it's just part of always the challenge that comes out with the physician fee schedule every year, that sort of jockeying between just different specialties. Some might get a higher rate, some might get a lower rate. And this is sort of sounds like it's almost a familiar story. Isn't
well,
right?
You're right in that, Kurt, in that CMS is constantly reevaluating code values. And this happens every year. Those people who do a really deep dive on the fee schedule understand and appreciate how these code values get adjusted to reflect improved efficiencies, some higher costs, some new technology, whatever it may be. The difference here is the magnitude of the adjustment. If you think about how frequently an E&M code is submitted to Medicare, it is by far. Those are the 5 E&M or 4 E&M, depending on whether it's a new or older recurring patient, are the most commonly billed codes. I mean, by far, by magnitude. It's like everybody's doing an E&M. Yeah. Only certain physicians are doing radiology. Only certain physicians. So if you make an adjustment, let's say if you bump up a radiology code, and it has very limited number of people who are billing that code, the financial implication to the Medicare program is not huge. And under that revenue neutrality, the amount of the adjustment, and you can spread it out, is almost negligible.
Okay.
But when you take a code adjustment for E&M codes, which are so pervasively used across all specialties, and the number of times, and you make that change, the magnitude of that is so large. The offset that you have to do becomes so pervasive, is why we're in this situation. It's uniquely because it's the E&M codes that were revalued.
Mm-hmm.
All codes are constantly being revalued, but we don't really feel that because it's spread out so much. It's almost negligible when you get it down. This one was so big is why it was having such an impact.
So yeah, so depending on your specialty, just because the conversion factor was going to be decreased for 2021, to adjust for those changes, certain specialties that do a lot of E&M were still projected to see an increase in Medicare payments with the new code values, even with the lower conversion factor. So each fee schedule contains a table of estimated RVU impacts per specialty. So suggest finding that table. It's linked to the summaries that HBMA puts out to try to understand the estimated impact. Again, that's before these 3.75% or now 3% adjustments that Congress adds on top of that to help mitigate losses that some specialties would see from those changes.
Right. And I wonder also, the federal government's been living under sequestration now for over a decade, which is part of the challenge. And then the other sort of challenge you point out is, there's this temporary increase, but the cost of everything is going up.
Right.
And of course, we know that inflation is way up this year. What's your prognostication for, maybe someday sequestration ending? Or maybe our budget, maybe becoming a little more reflective of reality, the fact that costs go up. We can't keep doing the same amount of providing the same level of service and care at the same level of financial support.
Well, the problem is, Kurt, you're absolutely right. The observation you made is perfectly logical. Unfortunately, the minute you use the word logic in the context of government policy, it's
Right.
like it almost becomes like a death knell.
Right.
But so let me try and unpack the observations you made. So as far as sequester is concerned, we'll talk about the 2% sequester.
Yeah.
That, when it was approved by Congress, was in fact supposed to be temporary.
Okay.
It was a 2% a year cut that was supposed to occur every year for 10 years. So when it was passed in, I think was it 2012 or 2013?
Somewhere around there, yeah.
Congress said, we're only going to do this for 10 years. We're going to use this to pay for the SGR fix that we needed to do, or not SGR, some of the SGR and some other things we needed to do, but it's going to be temporary. Well, then the next year they found they needed some money. So they said, well, instead of it expiring in 2022, it'll expire in 2023. And then the next year and the next year. And so now we're up to 2032, I think, is when it's now slated to expire. Well, if past is prologue, what I've been telling everybody is just assume that sequester, that 2% is here to stay. So instead of what Medicare historically and what the law technically says is you're supposed to get paid up to 80% of the allowable, providers should presume that you're only going to get 78.4% of the allowable, and that's what you should assume in perpetuity. Now, one of the things, and I didn't touch on it, is they are actually in this same bill actually proposing to bump up the sequester number from 2% to 3%.
Oh, really?
Beginning in 2030.
Well, great.
So
continue to cut.
Yeah. So instead of it being 78.4% in 2030, the Congress is proposing that the payments be reduced so you would only get 77.6% of the allowable beginning in 2030 instead of the 78.4 that you were going to get, or the 80% that the law says you should have gotten. So I think this is the gift that keeps on giving, that the Congress will continue to take advantage of, because in the congressional mindset, it's like, this is a painless cut, right? If I add a year on the back end, technically I'm saving money for the federal government, but I'm not taking it out of your pocket today. That money is already built in. That savings is already built in. I'm taking money out of your pocket in 10 years. And 10 years, maybe I'm not going to be around as an elected official, or you're going to forget that I voted to take money out of your pocket in 10 years.
Right.
So there's not going to be any political consequence to my extending it or whatever I propose to do in 2030 or 2032 or whatever year may be. That'll be long forgotten by the voters, by the people who care about that stuff by the time it happens.
Or it's the Grinch that keeps on Grinching. Maybe it's
yeah.
There you go.
Yep.
Wow. Well, and you start out with positive news, so that's good. And for us to be able to share, even though there's the Grinching challenge over the next decade or more.
Yeah, I mean, we never, it's never a full, hey, this is great. There's always the yin and the yang. It's like, okay, the good news is they're going to do this. The bad news is they're going to do this. But we were in some meetings. I've been in some meetings with Hill staff and different people over the last several days talking about this issue. And, one of the points that I've tried to make to them is, because they'll say, well, what do providers want? What is it that they want? And we'll get into some of the nitty gritty. I said, but you know what they really want? And I think it's, whether it's billing companies on behalf of their providers or their providers themselves, they want stability and predictability.
Right.
Tell me what I'm going to get paid to provide the services, and then I can figure out how I need to structure my office, how I need to look at my overhead, how I need to look at my volume, how I need to balance my payer mix, what I need to look at in terms of the kinds of patients I'm seeing. If I know what I'm going to get paid for this and have a reasonable expectation, I can structure my practice in such a way that I can survive and be successful financially. What becomes a big problem is when there's this fluctuation. Oh, well, we were going to pay you this, but now we're going to pay you X percentage less. Oh, we were going to pay you that, but now we're no longer covering that service. Oh, we were going to do this. And that just drives you crazy. It drives you crazy from a business perspective, from a financial perspective. So I said, stability, give us stability. Tell us what you're going to pay. Let us know. And then let folks figure out, let HBMA members figure out for their physicians, okay, how do you survive under this system from a business perspective? What is it that you need to do as a medical practice? And this is where the HBMA folks are expertise. It's, it's the healthcare business management is, if you know what you're going to get paid, what your historical costs have been, what your payer mix has been, what kinds of patients, and that's going to be projected out. Now let me know what you're going to pay me, and I can do a reasonable budget. I can do a reasonable projection. But if you're doing this whipsaw of, oh, it's going to be this today and it's this tomorrow, it just, it's not sustainable.
Right. It's even more of a challenge now, given all the unpredictability due to the pandemic and with patient volumes down and practices being stressed. So I'm glad that they're coming up with, some more of the money to slow down the sort of drawdown. Well, I guess call it that, but it still comes at a really unfortunate time. Not that there's ever a good time to get less money.
No, and that's really one of the arguments too that people have made is there's never a good time to take less, but the last time you would want to do it is in the midst of the financial havoc that's being created by the COVID pandemic. Because you're right that we're still feeling the effects of that, and in some states, I mean, what was it last week or so? The governor of New York unilaterally said, because of Omicron, we're going to cancel all elective surgery in order to ensure that we have sufficient beds to handle the surge that we think is going to occur from Omicron. Well, fortunately thus far, while Omicron is proving to be a very highly contagious form of COVID, the reports thus far clinically are that it's relatively mild. And may not, in fact, translate into a significant increase in hospitalizations, even though the case count might go up. Well, okay, what are we going to do in New York? You just now canceled all these elective surgeries. Those elective surgeries, that's revenue for a projected surge that likely now may not occur.
Yep.
So, what does that do for the cash flow of those institutions in New York who are projecting and counting on that revenue to help meet payroll, meet their expenses, meet their liabilities, whatever it may be?
Yeah. These are all great questions you raised, Bill. So I know one of the other topics that was suggested that we talk about was sort of a different topic altogether. It's more on the insurance side, and it was related to prior authorization. I don't know if you want to get into that, Bill or Matt, a little bit as well. And it's just a little bit of a pivot. I know we're already about 20 minutes into our discussion.
Well, prior authorization has been a thorn in the side of many providers for a long time, and in particular, certain specialties. So radiology is one, and prescription drugs is the other area where typically you'll see prior authorization. And insurance companies do that as a means. I mean, what they'll tell you is, well, we just want to make sure that it's really medically necessary, or that you're prescribing the right medication. Is that image the most appropriate? And so there has been efforts in the Medicare program to prevent Medicare Advantage plans from instituting prior authorization with regard to Medicare beneficiaries who are in these MA plans, in order to trust the judgment of the ordering professional, trust the judgment of the radiologist or whomever, that these are appropriate. And certainly there's a lot of arguments that the clinical justification sounds great on the one hand, but there's just tremendous abuse by the insurance companies of the prior authorization process. How long it takes to get prior authorization from the insurance company, the queries that come back, the types of issues. And very often these are situations where the patient needs that care, and you're just instituting this in the hopes that the patient will give up, or you'll decide, okay, it's a waste, we have to move on.
Yeah.
So HBMA and some others have been supportive of efforts to prevent insurance companies from using prior authorization as a means of inappropriate denial for care or services. It's not clear whether or not where that's going to go, and whether or not this will be successful. But I think this is an area that will increasingly draw attention of where is the line between what is an appropriate examination to ensure that services are medically necessary versus institution of barriers that are there simply to discourage patients, discourage providers from getting the care they need. Now, one of the things that was done in the Medicare program itself, in lieu of prior authorization, is where the ordering provider, there's technology out there that allows the ordering provider, instead of going through prior authorization, let's say in the imaging space for advanced imaging, should I order a CT? Should I order an MR? Or is a traditional X-ray an appropriate modality? And there's software now that Medicare, there's legislation that says beginning next year, the ordering professionals are going to have to consult certain software in order to help guide them as to what would be the most appropriate advanced imaging modality to order. Doesn't deny payment, but the provider will have to show evidence that they consulted this software to see, well, this is what I was trying to ascertain. This is what I ordered, and the software may come back and say, you ordered a CT, but in this case, an MR might have been more appropriate, or a PET, or whatever. And so they're looking at are there technological ways to try and ensure that the modality of imaging is the appropriate modality, not as a denial for the imaging, but rather to say, hey, maybe given the image you're trying to produce, maybe this was a better choice than that.
Yeah, and I'd say just to add to that, at least from the prior authorization side, because that's, as you pointed out, the appropriate use criteria model is an electronic process for doing it, and for many prior authorizations, it's still much more manual. So this bill that's been getting a lot of attention essentially requires Medicare Advantage plans to create an electronic process that can handle real-time prior authorizations to help at least expedite it at the very least, to make it a more efficient and manageable process.
Mm-hmm. And hopefully get a denial back sooner, so that way maybe an alternate could be formulated.
Right.
Exactly.
Right. Denial or approval. But Matt's absolutely right. Is if you are going to at least make this to be a very quick, painless process where here's what I want to do, and they can say, yeah, okay, fine.
Yeah. Okay. Well, I guess that's one that's further down the line, and we know that sometimes Congress moves very slowly until it doesn't, and then suddenly some things happen, at 1 a.m., and then we get 1,000-page bills that pass that solve all the world's problems. So we believe, right?
Well, yeah, I don't know about the solving problems. It's the kind of stuff I jokingly used to refer to it as the Bill Finerfrock Full Employment Act stuff, because every time they pass something, there's a gazillion regulations that they're going to have to pass in order to figure out what it is and how they're going to operationalize it, and then that takes people like me and Matt and others to go in and try and figure out what that means, so we can communicate it to folks like the HBMA membership, and how do you do that in the best interest of your clients.
All right. And then of course comes the comment period, depending on what the rules are, and then what the public doesn't understand, which I know you do, is legislation is one thing, and it takes years to actually be implemented. So
Yep.
Well, thank you both for joining us. I think this was insightful to share the latest updates on what was happening in Capitol Hill. Suspicious as it just happened a couple days ago, or maybe a couple nights ago, right?
Yeah.
And we'll watch to see what happens in the Senate.
Yep. Yeah, I do ask. I have to say, Kurt, when people tell me that something that I've said is insightful, in the verbal form, I often ask them to clarify. Is that spelled INSIGHT or INCITE? One is inflammatory and the other is informing. I hope what we've done is inform you, not inflame you.
Or if we're inflaming, then we can direct that energy, in the appropriate places to try to get the changes we need, right?
That's right. Right. It becomes a motivating entity. So.
And Bill and Matt, you'll be joining the HBMA community in just a few days to provide the annual Washington update.
Yeah, that's right.
Yep,
Thank you for mentioning that. Yeah, and we'll be kind of doing a look back more extensively at some of the things that have occurred, and then also looking forward. What is it that we're expecting to happen in 2022? Mm-hmm. What are the things that we're keeping our eye on? What are some of the things HBMA is going to be doing in the new year, so folks can have a sense of where we see things going and what HBMA is going to be doing on behalf of the membership.
And the date and time?
The 16th. I'm looking at the time right now at 1 p.m. 16th at 1 p.m.
Eastern, 1 o'clock Eastern.
There you go. Softball question for you to plug the session. So.
Yep, there you go. Appreciate that.
Well, thank you both. Happy holidays to both of you. Stay well, healthy, and we'll see you again in just a few days.
Very good. Thanks, Kurt.
Take care, everybody.
Be well, everybody.
Yep.
Thank you.
Thanks.